Hello friends, so let us now discuss the congenital disorders of the nose. So as we talked in the last topic, let us first discuss about choanal atresia. So as I just told you in the embryology that this choanal atresia is because of the persistence or the non-breakdown of oronasal membrane, the membrane between the primitive nasal cavity and the primitive oral cavity. So generally we know by 7 weeks of intrauterine life, this membrane breaks down and we have formation of primitive choana, which converts into definitive choana by 9 weeks of intrauterine life when the secondary palate is formed. Okay, now this is an extremely rare condition. It is like one case in 8,000 live births. Okay, so it is an extremely rare condition, all right, and generally seen in hyperthyroid mothers who have taken drugs such as methimazole or carbimazole, okay, generally given to hyperthyroid patients. So this can be a side effect of these drugs. All right, now this is generally unilateral. 2:1 ratio is there, so twice more common as unilateral, okay, than the bilateral. Now it was earlier thought that this atresia is 90% of times bony. The membrane is actually bone and 10% of times it is membranous. However, the recent studies have shown that 29% is pure bony and 71% is bony membranous mixed. That means that the pure membranous variety is extremely rare. Okay, it is almost nil, right? Okay, now let's look at this. What do we see over here? We can see unilateral choanal atresia. One side nose, as you can see over here, it is open, and on the other side it is closed. Okay, so this is a case of unilateral choanal atresia. Now how will this child present to us? Now remember, this child at the time of birth will not have any symptoms. Okay, so at birth there will be no symptoms. So this unilateral choanal atresia, it will escape detection at the time of birth. Now the child will come to you in later age group. When the child becomes a little intelligent, he is able to understand that he is not able to breathe from one side of the nose. Okay, so he'll have unilateral nasal obstruction. There will be unilateral nasal infections, nasal discharge. Because the nasal secretions are not able to go in, they will come out anteriorly. So patient will have unilateral nasal infection in the discharge. All right, so he'll come with these complaints in the later age group. All right, and we can see over here, this is the CT scan of a unilateral choanal atresia. You can see that on the right side the nasal cavity is clear, there is no obstruction, but on the left side we can see that there is a bony obstruction. Because of that, all this soft tissue or the secretions, they are collected inside the nasal cavity, right? So this is a case of unilateral choanal atresia. Not a very serious condition as we have seen. Now let's come to bilateral choanal atresia. So what can we see over here? We can see that both sides posterior choana is blocked. Okay, now how will this patient present? You see, at the time of birth, human beings, we are obligate nasal breathers. We are obligate nasal breathers. That means we cannot breathe through mouth at the time of birth. We can breathe only through nose. We are obligate nasal breathers. We cannot breathe through mouth. The mouth breathing we learn after 1 month of age, okay, after 4 weeks, 1 month of age, and that comes by practice. right? So at the time of birth, we are only obligate nasal breathers. Now in this patient, the nose is blocked. So the child cannot breathe through nose. He has not yet learned to breathe through mouth. So what will happen? The child will come to you, present to you with breathlessness, respiratory distress. Okay. So as soon as the child is born, the child goes into respiratory distress, and the way the respiratory distress is manifested is by cyanosis, bluish coloration, right? Okay, now how will you confirm your diagnosis? Now remember, this child will have a very, very particular feature. What is the feature? If you make this child cry, for crying the child, it opens up the mouth. So when it cries, it takes the air in, his mouth is open, he can breathe. He'll become pink, right? But as soon as the child goes silent, the mouth gets closed on its own and he tries to breathe through nose, he's not able to breathe. So he'll become cyanosed. So this question is an important question which has been asked multiple times in the exam. A child which is pink while crying and blue means cyanosed, while silent, what is your diagnosis? The diagnosis is bilateral choanal atresia. Okay, how will you confirm the diagnosis? Now you see, just after the child is born, in the neonatal resuscitation, we have to suction out the meconium or the secretions, whatever is there in the mouth and the nasal cavity. So what we do is, we put a suction cannula in the mouth. Okay, first we always put in the mouth and we suction it out from the mouth and the throat, and then we put it in the nose. Okay, so when as a pediatric intern or a pediatric PG, you will put this in the nose, what will happen? There is a choanal atresia. It will rotate and come back. Okay, so immediately you will put it on the other side, other nasal cavity, and it again rotates and come back, and you have made your diagnosis within a few months. So you have made your diagnosis within a few minutes of the childbirth, okay, that the child is having choanal atresia. Okay, just by this simple procedure, you are able to diagnose the patient is having bilateral choanal atresia. So what can you do? Okay, what can you do? How can you confirm your diagnosis? See, the confirmation of diagnosis will require CT scan. Just like over here, we can do the CT scan in the later when the child is stabilized. We can do the CT scan and we can establish the diagnosis. We can see over here that there is bilateral choanal atresia, right? Okay, but how will you manage the patient at that time, right? CT scan can be done later on, but how will you manage? You see, the child does not have a nasal airway. The child is not able to breathe, and you have a few minutes so that to give a good airway to the child so that he can breathe. So now the best thing that you can do is you can insert a Goodell's oropharyngeal airway. Very simple to put. Okay, so you insert the Goodell's oropharyngeal airway in the mouth, and this will keep the mouth open. Okay, it will also prevent the tongue fall, and this will provide an airway to the child. The child will be able to breathe. Now, suppose you are taking the delivery in a domiciliary setting, in a home care setting. Okay, you are not in the hospital and you don't have an access to a Goodell's oropharyngeal airway. What can you do at that time? Now there, instead of this airway, you can put a nipple with a wide hole. This is known as McGovern's technique, all right? So you can put a wide bore nipple, right? And this will act as an airway for the child till the child can be transported to a higher center for the treatment, right? So this is your McGovern's technique. What treatment will you give for the bilateral choanal atresia? You see, bilateral choanal atresia is a life-threatening condition. So we have to operate the patient as soon as we can get all the clearances, and the surgery is we have to excise the atresia part. Okay, for excising the atresia part, we may have to even drill the bone, right? So the treatment for choanal atresia is endoscopic excision of the atresia part, right? We may have to use the drill, we may have to drill the bone because it is 29% of times pure bony and remaining 71% of times it is bony membranous mixed. Okay, so we'll have to use the bone in almost bone drill in almost all the cases to remove the bone, and it is now preferentially done endoscopically. Okay, right. Now before I finish this topic of choanal atresia, remember choanal atresia is a part of a syndrome known as charge syndrome. Okay, what is there in the charge syndrome? In the charge syndrome, the C stands for coloboma, coloboma of the eye. H is for heart defects such as ASD, VSD, TOF, etc. The A stands for atresia of choana. Okay, R is for retardation, mental retardation, and G is for genitourinary hypoplasia. The E stands for ear defects. Okay, the ear anomalies which can be present. So together this is known as charge syndrome. So remember, the atresia can be a part of the charge syndrome. So whenever you get a patient of choanal atresia, we cannot rush to the surgery. We have to first evaluate the patient and rule out other conditions which may complicate the anesthetic drugs which are given during the surgery. Okay, so we'll have to take care of all these things also before we go for the surgery. Right, let's come to the next condition. The next congenital condition is known as nasoalveolar or nasolabial or clefted cyst. Okay, now first thing about these cysts, these do not have a dental origin, they are non-odontogenic. Now, how are these cyst forms? They are generally in the incisive for a canal, and there are two theories of formation of the nasoalveolar cyst. Usually it is said to be formed from the nasolacrimal duct. Okay, in the embryonic stage, remember, we saw that the nasolacrimal duct was forming from the naso-optic groove which was present between the maxillary process and the intermaxillary process. Right, now these are painless swelling, cystic swelling, which are generally present over here in the nasolabial area. Okay, in the area of the nasolabial fold. Right, so as you can see over here, this is the cyst which is present, usually seen in females around 40 to 60 year age group, and the treatment is we can easily excise them by the sublabial approach. Okay, so we can give an incision over here and we can take out this cyst. Right, so surgical excision by the sublabial approach is the treatment given for the nasoalveolar cyst. Right, now the next that we should differentiate this cyst from is the dentigerous cyst. Okay, the dentigerous cyst or the follicular cyst, as the name suggests to you, these are of dental origin. Now these cysts, they develop from the unerupted or partially erupted tooth. Most commonly is the third mandibular molar, the wisdom tooth, or from the maxillary canine. So these are the most common to form the dentigerous cyst or the follicular cyst. Now what happens that in the unerupted tooth, the epithelium around the enamel that is embedded and it forms the cyst. So there is a collection of all the dead epithelium and they form the cyst. So typically in the CT scan you will see that there is a soft tissue density, there is a cystic mass over here, and in between you can also see the tooth. right? So remember, you will always see the tooth over here in this cyst, right? Here also you can see this tooth in the cyst, right? Now remember, these are both the maxillary cysts. They are in the maxilla, so they are also going in the maxillary cavity, the maxillary antrum. Okay, they can also be in the mandible. We have discussed the third mandibular molar is the common, and these cysts, they grow rapidly. So because they grow rapidly, the bone around them will become weak, and because of that they can even cause mandibular fractures because the bone gets very weak, right? How will we treat them? The treatment is again surgical excision. Okay, so we try to excise them, and if we are not able to excise them completely, we'll marsupialize them. But the ideal treatment is excision along with extraction of the tooth. You have to remove the tooth. If you do not remove the tooth, the cyst can form again, right? Okay, so these are dentigerous cyst or follicular cyst. Now, before we end, let's discuss encephalocele and meningocele. What is the difference between encephalocele and meningocele? Meningocele is a herniation of the meninges of the brain. Meninges are the brain covering. So when only the meninges they herniate and come out, they are known as meningocele. Okay. Now, if these meninges they also have brain tissue in them, then they are known as meningoencephalocele. Okay, so encephalocele means that there is a brain tissue present, right? Okay, now we also have hydroencephalomenococeles, in which we also have the ventricle along with the meningoencephalocele. So obviously you can see this is the most severe variety, right? Now these can develop because of a defect of the roof of the nasal cavity. So, you know, the brain or the meninges, they can herniate out into the nose, or they can come out on the face also. All right. So we can have the encephalocele or the meningoceles in a newborn also. Remember, first thing, any polyp-like mass seen in the nasal cavity in a newborn, in a child, it is likely to be a meningocele or encephalocele. Okay, so a young newborn or an infant, you don't have polyp because of the sinuses or any other reason. If there is a polyp in the nasal cavity, please don't try to pluck it. It can be an encephalocele or a meningocele. You may damage it. Patient may have a CSF leakage. Okay, so any polyp in a very young child, in an infant or a newborn, you have to be very, very careful. Okay, now, so these are typically present at birth. The most common location is occipital, followed by frontal. Now the frontal variety, you see, it is coming from the nose and out. It can have nasal obstruction. It can cause nasal obstruction because it is there in the nose also, right? We can have hydrocephalus. Along with that, we can have the eyeball and the lacrimal duct defects, because all this part is defective, and that is why there is herniation. Okay, and because of the herniation of the brain tissue, patient can have neurological defects also, right? And as I told you, there is an intranasal mass, so obviously it can lead to nasal obstruction, right? Now, what will you find on examination? You can see that there is a mass over here. This is a bluish, soft, pulsatile and compressible swelling. Because the brain is supplied by blood supply, so it is a pulsatile mass, it is compressible swelling, right? You can press it because it is in communication with the brain. Now, if you do a trans-elimination test, it is positive. So remember, the trans-elimination test is positive. Also, if you press the jugular vein, it will stop the blood coming out of the brain. It will increase the pressure in the brain. Similarly, during coughing, sneezing or straining, again the brain pressure is increased and that will lead to increase in size of this mass. This is known as Furstenberg's test. Okay, so Furstenberg's test is positive in encephalocele. The mass increases in size on coughing, sneezing, straining, or even by pressing the jugular vein. Right? This is because this mass is in direct communication with the cranial cavity. Right? Now, for imaging, we have to do both CT scan and MRI. Why? The CT scan is required to know the bony defect. The MRI is needed to see the soft tissue, the brain tissue inside, and therefore both are necessary before planning the treatment. The treatment is, we generally try to replace it back, but we have to repair the defect of the skull base. Okay, so the treatment is mainly directed at repair of the skull base. Otherwise, without that, it can recur. Okay, now a condition that is very similar to that, however different condition, is known as nasal glioma. Okay, nasal glioma, also known as nasal glial heterotopia or glial hematoma. Now, what is there? What is the difference? Now, these nasal gliomas, they have brain tissue, okay, but they have separated away from the cranial cavity. That means they do not have any communication with the cranial cavity. So, they are non-compressible. Okay, these swellings, they are non-compressible swelling, and therefore Furstenberg test will also be negative. Right? So patient can present a mass, the nasal glioma. It can be extranasal. Almost 60% cases are extranasal, and as you can see, it is a subcutaneous mass on the subcutaneous bridge of the nose, or we can have an intranasal in the superior nasal cavity. As I was telling you, if there is a polyp, do not try to pluck it in a newborn or an infant. Right? And it can be also a mixed mass, both intranasal and extranasal, and these are generally very large lesions. Right? Okay, now remember, nasal gliomas, they are non-compressible swellings. Number 2, the Furstenberg's test is negative. Number 3, the trans-illumination test is also negative. Right? Okay, so all these 3 tests are negative, and this is how you can differentiate nasal glioma from the meningocele or meningoencephalocele. The treatment is, you can excise them. Of course, before that you have to do a CT scan and MRI. Both investigations are needed to check if there is some bony defect also present. If there is a bony defect, you have to repair that also. Usually bony defects are not seen over here like we seen in meningocele or meningoencephalocele. Okay, right? So the treatment includes the excision plus if any repair is required. Okay, again we will use both CT and MRI for the imaging of nasal gliomas also. Right?